Hey, welcome to The Explainer. Today, we're going to tackle a huge topic, how we treat inflammatory bowel disease. This one's specifically for you trainees out there, so we're going to walk through the classic step-up approach step by step.
Okay, so here's how we're going to break this down. First, we'll talk about what we're actually trying to accomplish with IBD therapy. What's the end goal? Then we'll get into the nitty-gritty of the drugs, starting with the first step, the 5 ASAs. After that, we'll cover how to handle flares with corticosteroids, and then the really important part, how to keep patients in remission using thiopurines. And finally, we'll zoom out and talk about the long game, all that essential health maintenance stuff.
So, before we jump into the pharmacy, let's just pause for a second. When you have a patient with IBD sitting in front of you, what's the actual goal here? What are we really trying to do? And the answer is, it's so much more than just, getting the diarrhea to stop. The real prize, the holy grail of IBD management, is getting the patient into a long-term, steroid-free remission and keeping them there.
So how do we get there? We use what's called the step-up model. I want you to picture a pyramid. We start at the bottom, the widest part, with the foundational therapies for milder disease. And then only if we need to, we climb up or step up to stronger medications for patients who are sicker or aren't responding.
All right, let's start at the base of that pyramid. We're talking about the first step, aminosalicylates, or 5 ASAs. So picture this, you've got a patient with a mild flare, especially if it's ulcerative colitis. Your first move, your go-to play is very likely going to be a 5 ASA. Okay, now this is a really cool slide because it gets at a super important point. Not all 5 ASAs are the same. It's not just about the drug, it's about where the drug gets released in the gut. The magic is all in the formulation. For example, if you've got inflammation all the way from the duodenum down to the colon, something like Pentasa, which is diffusion dependent, makes a lot of sense. But hey, if the disease is only in the colon, then a drug like sulfasalazine, which actually needs bacteria in the colon to get activated, is a much smarter, more targeted choice. It's kind of like precision medicine, but with our oldest drugs. Now, these drugs are usually pretty well tolerated, but there are a couple of things you absolutely have to keep on your radar. First, and this is a big one, is nephrotoxicity, kidney injury. That's why you'll be checking their creatinine every few months. Do not skip this. The second one is a classic for exams. Every once in a while, a patient will actually get worse when you start them on a 5 ASA. It's rare, but if it happens, don't just automatically think the disease is flaring. You have to consider that the drug itself could be the culprit. Okay, so what if your patient comes in with a moderate to severe flare? The 5 ASAs just aren't enough to put out the fire. This is when we have to call in the big guns to get things under control, and that means corticosteroids. All right, listen up, because if you remember one thing about steroids and IBD, make it this. Corticosteroids are a bridge, not a destination. I love the fire department analogy. They are absolutely fantastic for putting out a raging fire. That's the acute flare. But you wouldn't ask the firefighters to move in and live with you, right? That's the same with steroids. They get you out of trouble, but our goal is always to build a safer, long-term bridge with other medications so we can get the patient off the steroids completely. They are not a maintenance drug. Okay, so we've put out the fire with steroids. Now we need to build that long-term bridge. That brings us to our next step up the pyramid, the thiopurines. We're talking about azathioprine and its active metabolite, 6-mercaptopurine. These guys are the real workhorses for keeping patients in that beautiful, steroid-free remission we worked so hard to get. Now, before you even pick up a pen or, open the EMR to prescribe one of these, there is one test you absolutely positively must order. It's the TPMT enzyme activity. Why? Because this enzyme is what metabolizes the drug. And if your patient has low or no activity and you give them a standard dose, you could cause severe, life-threatening bone marrow suppression. This isn't optional. This single test is the key to personalizing the dose and keeping your patient safe right from the start. And here's what that looks like in practice. It's a perfect example of personalized medicine. About 90% of your patients will have normal TPMT activity. For them, you can start with the standard weight-based dose. But for that other 10% who are intermediate metabolizers, you have to cut that starting dose in half. It's that simple. Doing this prevents some really nasty side effects like myelosuppression. So you've checked the TPMT, you've started the drug. Are we done? Nope. It's not a set it and forget it situation. How do we actually know if the dose is right? Are we in that sweet spot, the therapeutic window? Or are we underdosing them? Or worse, causing some kind of silent toxicity? The answer is, we check their drug metabolite levels. And this table, you guys, this is high-yield gold, not just for your boards, but for the wards. It basically lets you be a detective. You're looking at 2 metabolites, 6-TGN, that's the good guy, the therapeutic one, and 6-MMP, that's the bad guy, the one linked to liver toxicity. So look at that first row. If both are low, the patient probably isn't taking their medicine. Simple as that. But now look at the third row. This one's fascinating. The good metabolite is low, but the bad one is high. This person is a shunter. Their body is preferentially sending the drug down a toxic pathway. By checking these levels, you can figure out what's really going on and fine-tune the therapy instead of just flying blind.
Okay, so checking metabolites helps us manage common problems like toxicity. But there's another risk we have to talk about. It's much, much rarer, but it's also incredibly serious. This is something you won't see on the labs, but you absolutely have to know about it so you can have a proper informed consent discussion with your patient.
We're talking about hepatosplenic T-cell lymphoma, or HSTCL. It's a very aggressive and almost always fatal type of cancer. Now, for most people on these drugs, the risk is tiny, but it does seem to be concentrated in a very specific group. We're talking about young male patients, especially if they're on a thiopurine plus an anti-TNF biologic for more than 2 years. So, what's the actual number? In that highest risk group, the young men on combination therapy, the risk is estimated to be around 1 in 3,500. Now, that's still a rare event, for sure. But when you're talking about a fatal cancer, it's a risk that absolutely has to be part of the conversation when you're weighing the pros and cons of different treatment strategies. All right, we've gone deep on the drugs, but managing IBD is so much more than just writing prescriptions and controlling flares. We have to zoom out and think about the whole patient. This is about proactive, long-term health maintenance.
It's so easy to just focus on the gut, but you have to remember that you are this patient's key physician. This checklist is kind of your safety net. Big things to remember. Vaccinations are key, but the #1 rule is no live vaccines for anyone on immunosuppressive therapy. You are also in charge of their cancer screening. That means annual skin checks because of the thiopurines, regular pap smears for women, and of course, surveillance colonoscopies for colon cancer. And lastly, because so many of these patients have been on steroids, you always have to be thinking about their bone health.
And really, that's the take-home message here. Our job isn't just to treat the Crohn's or the ulcerative colitis. It's to care for the whole person. All of this proactive maintenance stuff is every bit as important as picking the right drug to treat their flare. And that just about wraps it up. We've walked through the classic step-up approach, which has been the standard for years. But I want to leave you with a question, because the field is changing so fast. With all the incredibly effective new biologics we have, the big question on everyone's mind is, will the future of IBD therapy be about stepping down? Can we hit the disease hard up front and then maybe de-escalate therapy once we've achieved a really deep remission? That's really the question that's driving a ton of research right now, and it's an exciting place to be.